Well, welcome to mental health, right? Does everybody have access to, I think it's called Mood Affect PowerPoint in Canvas? Okay, I know you guys all know me, but I'm still gonna introduce myself. I'm Sarah Rammel. You guys know me from Population Health. I was some of your instructors in clinical, but so we're gonna get started. What do you guys know about depressive disorders? What's the first thing that comes to mind? Depression, mental health, okay. What else? What's that? Mood changes, absolutely. Negative effects. What are some negative effects? Sadness, not wanting to leave your house. So we'll get into some of that as well, but I just want you guys to kind of think about depressive disorders, your affect, kind of throughout this entire conversation that we're going to have today, and just kind of think about it. And I'm sure we can all come think about in our brain somebody that probably has most of this in their lives, whether it's a personal or a friend, a grandparent, whomever, a sibling. We can all probably envision somebody with all of these, with these disorders that we're going to talk about today. Okay, concept of mood and affect are emotions. Are there good emotions and bad emotions? Right? Do we experience both of them on a daily basis? Most of us do, right? We can't always be happy or always be sad, or we can, but most of us have different times throughout the day that we might feel something different. So it's just a response to a variety of stimuli. Something that makes me happy might make you really, really sad. Or something that makes you sad or happy might make me feel the opposite way, depending on maybe our history or how we grew up, whatever it is. So positive emotions that most of the time are positive for people: joy, happiness, being excited, feeling excited about something. Some of those negative emotions: fear, sadness, jealousy, right? Those are all feelings that most of us feel are fairly negative emotions. So if we talk about depressive disorders, they all have some very common symptoms. All of the disorders do. Sadness, emptiness, irritability, impairment of thinking. I mean, I feel like some days that we all could have some of these feelings, depending on what's going on in our lives, right? This impacts our ability to function. If you are feeling sadness, empty, irritable all the time, you're gonna not wanna get out of bed. You're gonna not wanna call your friends. You're not gonna want to go do things with people. You're gonna not answer your phone. You're not gonna answer your texts after so long. So it's just that ability to function on our daily lives, like our activities of daily living, which include what? When we chart that at the hospital, what is included in activities of daily living? Showering, brushing your teeth, going to the bathroom, walking, ambulating, absolutely. So those are all things that, as that sadness and hopelessness starts to encompass your life, you're gonna stop doing some of the things of just daily living. The other thing I want to talk about is with the depressive disorders, you do want to rule out any actual health diagnosis. What's a diagnosis that you could come up with that maybe has some of these as signs and symptoms of, like a medical diagnosis that's not a depressive diagnosis? PTSD kind of encompasses some of mental health. I'm talking about, like, what's
like someone losing a limb.
losing a limb? That still maybe is a little bit some mental health. I'm talking about, like, let's talk about like thyroid, right? If you are hypothyroid, you're gonna be irritable. You're gonna have some feelings of depression. You're going to not want to do things. It's gonna look maybe like depression, but then as soon as maybe you get it diagnosed and you get it, you're gonna treat it, maybe those feelings go away. So it wasn't actually a depressive disorder, it was more hypothyroidism, that once you get treated, those feelings may go away. So you first wanna rule out any actual physical diagnosis before you go down the path of a depressive disorder. Okay, so let's read this case study. Rachel, you want to read it for us?
Jeff 19 is brought to the hospital after a suicide attempt. His parents found him in the backyard wearing his favorite black jeans and black t-shirt, but with one of his father's neckties. He had overdosed on some of his mother's pills, but his stomach was pumped in time. He has just been admitted Tier 4 for 24-hour suicide observation.
Okay, so as nurses, 24-hour suicide observation, what is the first thing we need to do for Jeff? Clear out the room that they could harm themselves with. We take just about everything out of their rooms, right? Anything sharp, anything with strings, sheets, anything that they could harm themselves with. Hard objects, everything. Okay, so we're gonna clear the room for safety. What else?
Make sure there's always someone in the room.
Constant observer, right? If somebody from the family can't be there, and what's the thing with having somebody from the family be in there? You want to make sure that they're also going to keep the patient safe, right? So we have to do a little detective work sometimes and be like, you know what, we're actually going to have one of our hospital personnel also sit in the room, because we want to make sure that the person that's in the room with them wants to keep them safe as well, right? So yep, having somebody with them, clearing their room. What else is important for Jeff? Yeah, what are your resources? Case management, social work, maybe a mental, I mean, he's probably, if he's being placed on suicide observation, he's probably going to have some kind of a therapist or a counselor or psychiatrist involved in his care.
They put him in a certain gown, so people know.
Safe
that, like,
gowns.
they left the room.
Okay.
Exactly.
Okay. What about, are we just gonna send Jeff home after 24 hours? Just say, see ya, buddy, good luck. No, we're gonna have to try and make a plan for his care, right? Wanna make sure he's safe going home. All right, what else do you guys think for Jeff?
Communicating like effectively, like not, like using more of like a therapeutic communication.
Therapeutic communication, that's our favorite word in mental health, isn't it? Right? We don't wanna be judgmental. We don't want him to feel guilty for the thoughts that he's having. We wanna make sure that we're helping him, okay? So some of the disorders that we're gonna talk about, disruptive mood dysregulation disorder. This is often mostly diagnosed in kids 6 to 18, but it usually kind of comes to fruition around age 10, or an onset before age 10. Okay, so with this particular one, we're gonna see more kids, obviously. So constant and severe irritability and anger, we see that in kids, but it's constant. Our kids, when you have kids, you're gonna be like, oh my gosh, you are so angry today, like what's the matter? Well, that's typical for kids to be angry or irritable on a given day, but this is constant, this is all the time. There's nothing that is helping them not be this way. Temper tantrums out of proportion to the situation at least 3 times per week. You guys will see some crazy tantrums in kids. But most of the time, maybe not to us, to them, it's in proportion, but we will know this tantrum is so out of proportion to the situation that's occurring, and they're doing that multiple times a week. We have to start wondering, is there something else maybe going on? And then they exhibit these symptoms in 2 of 3 settings, and I don't, this picture must have taken part of that away, but what it says is home, school, and with their peers, so their friends. These temper tantrums that are out of proportion are occurring in 2 of those 3 places. So maybe it's at school and at home, or it's at school and with their friends, or it's at home and with their friends. So it just has to be at least 2 of those. So how do we treat it? You're gonna end up probably treating it with meds, which is Risperidol or Abilify, which with the posters, did anybody do either of those medications? No, okay, well, we'll talk about those in a little bit then. Cognitive behavioral therapy is what we normally will see if they go in and they talk to somebody and they try to kind of change their thoughts and behaviors and and try to kind of funnel them in a different direction. And then we also, if it's a kid that's having issues, we probably are going to need to have some parent training as well. What do you think that includes?
Like how to react to like a temper tantrum.
How to react appropriately to a temper tantrum? That's hard. Trust me, it's hard. Sometimes you want to scream right back at them. Well, that's probably not going to help the situation, especially if the kiddo has this diagnosis. Any questions about that one? The persistent depressive disorder is going to be more of a disorder that we're going to see probably a little bit more often. So this is depressive feelings through most of each day for the majority of the days. So when we're asking patients, do you feel sad more days than you don't? Or how many days a week do you feel hopeless? Those are the kinds of questions that you're going to start seeing. Yeah, I feel sad more days than I feel happy. Okay, that's going to be more of that persistent. Like there are sometimes, like for a week, you might be really, really sad. There's kind of something that you're sad about, and then maybe you either deal with it or you move on or whatever it is. And you're sad for a couple of days, but this is persistent. Depressive feelings for the majority of your day, or for the most of the day for the majority of days. At least 2 years in adults. That kind of surprised me. I didn't realize that it was persistent was for 2 years in adults, and then at least 1 year in children and adolescents. They also must have 2 or more of the following, which a lot of these were ones we talked about. They don't want to eat, or maybe they eat too much. Those are both, they're in the same realm of things. Either they won't eat at all or they overeat. They're either exhausted and they can't sleep, but they're so exhausted that they don't want to sleep. They don't have any energy, they don't have any self-esteem, have a hard time just getting thoughts together. And then anhedonia is, they can't find joy in things. Their inability to experience joy. Not the normal things that make people happy, they're not making those happy. They're making that person feel happy. So that's that anhedonia. The persistent depressive disorder often starts in the teen years, and a lot of times either physicians, providers, parents, they're like, oh, they're just teenagers, they'll grow out of it. But it usually starts kind of accumulating in those teenage years. And it just kind of never gets any better for those patients. Some other depressive disorders, there's substance-induced depressive disorder. So this person does not experience just depressive symptoms in the absences of drugs or alcohol. Have you witnessed this in any time, in any situation? What do you guys think? Haven't really witnessed it. That's okay. And then there's also depressive disorders that are associated with another medical condition. So, like CVAs, Parkinson's, Alzheimer's, Cushing's, all of those kinds of things that we talked about. Some of them can cause depressive feelings, but also some of them kind of encompass depressive feelings. So sometimes you have to, even though the person, if they hadn't been diagnosed with Alzheimer's, maybe wouldn't have a depressive disorder, they may need medications for that depressive disorder, even while treating some of these disease processes. We already talked about that. Always rule out that medical condition first. But again, they may still need some of those depressive medications to deal with some of the thoughts. If we look at a 2-week period of time, if they have 5 or more of these signs and symptoms, it's fairly likely that they're going to be able to be diagnosed with a depressive disorder. We kind of already talked about some of these. Loss of ability to concentrate. They can't maybe carry on a conversation with you. They're very, I always say flighty, like they're like, oh, this, and then, ooh, something's shiny over here, let's talk about this, ooh, something's over here. They just can't have a conversation that flows nicely. The psychomotor agitation, does anybody know what that is? You see a patient or anybody who's fidgets all the time, is always tapping their fingers, twirling a pen. That doesn't necessarily mean that you have a depressive disorder if you do those things, but if you have that and 4 other things, you might think about it, right? Just tapping your toe or pacing, all of those things, that in and of itself isn't something that would diagnose you with a depressive disorder, but that in conjunction with other things. And then at least one symptom is either depressed mood or loss of interest or pleasure, that anhedonia. Okay? This one is just kind of the same things, just in little boxes now. Persistent of at least 2 weeks to about 6 months, lasting more than 2 years. It's recurrent episodes are common. So you might feel pretty good for a while and then all of a sudden you're kind of back down again. So it is happening often. It impairs your function for those daily living activities that we talked about. You don't want to shower anymore. You don't want to brush your teeth. Eating too much or not enough. Not sleeping or sleeping all the time. Those kinds of things. This is something that oftentimes as nurses we don't think about a lot, but we have to differentiate depression from grief. Do you think they look similar? Why? Sadness. What else?
Like isolating yourself.
Isolation, right?
Like with the same symptoms.
Yeah, they have the same kinds of symptoms sometimes. You sleep all the time or you can't sleep, you eat too much, you don't eat enough, right? So how would we decipher between them or differentiate between them?
Figure out if there's like they've had like any death in their family recently.
Right, and how do we do that?
Ask them questions.
Ask them questions, right? That's the first thing we're gonna do if a patient comes in and they're having some of these depression symptoms. You're gonna be like, have you had any trauma in the last year? Have you had a loss in the last year? And if they say no, then we're gonna steer down this route. If they say yes, then we're gonna come ask some questions about that. About 18 months or longer for major traumatic situations, you can still be going through grief during those 18 months. I mean, grief can last forever, but we want to make sure that we're getting a full picture, that when we talk to patients, it's not this 10 minutes that this patient is in front of you. We have to get a full picture of what has been going on in their life. How have they been interacting with other people for an extended period of time? It says may be difficult when working with new clients for that reason. If we don't know this patient, maybe they have kind of a flat affect to begin with. Maybe they don't ever smile in general, but they're not depressed. But they come in and they talk to us and we're like, there's something going on with this patient. We need to figure this out. And then you get to talking to them and they talk about all the fun things they're doing, but they just don't really ever have any facial expressions that say they're happy. So you just have to continue to talk, have that therapeutic communication, and learn about our patients. Seasonal affective disorder. Who has that for population health? You're gonna go present at Edgewood with. Who's doing seasonal affective disorder? Cameron, have you learned anything about it yet, or have you not gotten that far? Not far yet, okay. So, what do you guys think of when you think about seasonal affective disorder? Sad. It's kind of sad.
Normally people are sad during the winter time.
Why? Why are people sad during the winter times?
It's sunny, it gets darker quicker. It's cold.
It's not time, yeah, okay. It's cold.
Nobody's tan.
Nobody's what?
Nobody's tan.
Nobody's tan, everybody's pale. Okay, so outside of seasonal affective disorder, who else do you think can have some of these same symptoms in our line of work? people in isolation, but I'm talking about like nurses.
People who work night shifts.
Yeah, people who work night shifts, right? If you're awake when everybody else is sleeping and then you have to sleep during the day, you don't ever get that rhythmic sleep pattern down, okay? So depressive disorder that relates to the seasons. You can have it during the summer. It's probably not quite as common. It's usually in the winter months because like we talked about, it's going to be, it gets dark, like our days are longer. There's not as much sunshine. Today's beautiful, right? We all get out there and we feel the sun on our face. It just kind of gives us a little perk in our step, and we feel maybe a little bit better for a day until it's minus 20 again. Natural light is always going to be more helpful in our circadian rhythm than lights in a classroom, but getting outside, getting that sun. Bupropion is an extended release medication that can be used for this particular disorder. Behavioral therapy and light therapy, right? I don't remember what year it was, but buying like, I don't even remember what they were called. On Amazon, you could buy these lights that were proven to boost your mood. They didn't last very long, like the fad didn't last very long. I think they're probably still out there, but everybody and their dog bought these mood boosting lights. I swear to God, they were just like a lamp. I don't know what they were, I didn't buy one. But they do have light therapy that's actual light therapy. You probably can't buy it on Amazon. Any questions about that? Oh, the other thing I was gonna say is, it's not an actual official diagnosis in the DSM-5, but it is kind of encompasses some other mood disorders. So, get out and get some sun on your face, guys, right? What area of the United States do you think can have more seasonal affective disorder diagnosis? What's that?
People that get seasons, like the Midwest that gets all 4 seasons.
Okay. People that get all the 4 seasons maybe don't have it as much or have it more.
Not more, because they
Okay.
get winter down south, you don't get one year.
Yeah,
More
true.
summer.
What about, is there a state that doesn't get sunlight for,
Alaska.
do you think they probably have a little bit of seasonal affective disorder when it's never light? Maybe the little lamps would be really good for people who live in Alaska. But, all right. Postpartum depression. What do you guys know about that? After pregnancy, how long after you have a baby? It can vary, okay. Who do you think's more at risk for having postpartum depression? Pregnant women, that's fair, okay. First time moms, okay. What else is over here? People that have losses, okay, absolutely. What else?
Like maybe if you're a single mother.
Okay, if you don't have a good support system, absolutely. Do you think somebody who already has a diagnosis of a depressive disorder is at higher risk of having postpartum depression? Absolutely. So if you have a history of depression, if you feel like you're having a difficult time bonding with your baby, a lot of moms think it's just a very natural occurrence that you have this baby, you bond with this baby during pregnancy, and then you deliver this beautiful baby, and you're holding the baby, and all you want to do is hold the baby and look at the baby, and maybe they don't feel that way. And they're like, oh my gosh, I'm not bonding with my baby. Now what? And it may be a very short-lived thing, or it might be long-term, you just don't know. But they don't feel that motherly instinct that everybody thinks is just automatic, okay? If you have postpartum depression with another pregnancy, with prior pregnancies, you're at a higher risk of postpartum depression. A lot of sadness, crying, insomnia, fatigue, anxiety, feelings of not being able to take care of your baby. Now, these things can all happen and not be diagnosable postpartum depression as well, because these are all very common in brand new moms that have no history of depression. You're exhausted. Maybe you had a 24-hour labor and you now can't sleep because your baby's up all the time. Is there something going on with the camera?
It fell down.
What? Oh, it fell down. Like all of a sudden I heard all you. So postpartum blues is very, very common. That's when you are watching a commercial on TV and you have a brand new baby in your arms and you just start crying. And you're like, oh my gosh, I don't normally cry at these things. You kind of have that emotions, that those hormones are all wreaking havoc on your body. Postpartum blues are very common. But if it lasts after 2 weeks, that's when we have to start looking at maybe some postpartum depression, okay? There's also postpartum psychosis that we'll actually get into quite a bit more in OB, but that's kind of that next level. This is where you hear of moms maybe drowning their 5 kids in the bathtub before their significant other comes home. Like that's a whole nother level outside of postpartum depression. There are some medications that moms who are breastfeeding that they can take. Our goal, if they don't have other history of depression, with postpartum depression is to wean them off some of those medications after they start feeling better. Case study, okay. During intake, so now Jeff was the one that we talked about. Jeff is now during intake. He doesn't speak much, but his parents are able to list the following symptoms that they have seen from Jeff. Weight loss and appetite changes, insomnia, fatigue, worthlessness or guilt, loss of interest in his college classes, and even the online games he usually plays with his friends, and constant sadness. So this is intake. So this is when we're interviewing Jeff and his family, which he's 19, so I'm not sure why. His parents probably don't have to be there, or if he would like his parents to step out, they probably should, because he's 19. But what do we think about Jeff now? This is what we're learning about him.
Probably experiencing some sort of depression.
Probably experiencing some form of depression. And why do you think that?
Like his life, or like something that's changed in his life, it's just making him depressed.
Yeah, kind of one of the things that I see, especially for teenage kids, the online games he usually plays with his friends, he's finding no interest in that, right? That's kind of one of our first clues, like, okay, something's going on in Jeff's life. Is it happening because of his friends, or is there something else happening in his life that is causing him to not want to do the things that he's previously enjoyed? Okay, so what's one of the questions that we might want to ask Jeff?
When did you start feeling like?
How long have you been feeling this way? What if he's like, I don't know. He's like, is not interested in answering your questions. One of the hardest parts of therapeutic communication is finding a way to get them to talk to you, right? Because we don't want to make them mad and completely shut them down, right? But we also want to make sure that we're asking our questions so that we can keep him safe.
Maybe like asking what kind of online games he used to play.
Well, that's a good question. I wouldn't have thought about that. What kind of online games are you playing? That's a great question. Excellent. Okay, what else?
Maybe ask if there was like a certain onset that like started things. He's in college, so like maybe something happened between his friends, or like classes are really hard, so like asking him about his classes.
Absolutely. What kind of preceded you feeling like this? Is this new, or have you just been hiding it, been able to hide it from your parents for a really long time, and now something's happened and it's worse? Absolutely. Good. Okay, a little audience response question in here. Jeff's parents have described his lack of interest in things he used to enjoy, like games with his friends, his classes, which he used to like. This may be best described by what term? What term up there means things he used to like, he does not enjoy anymore? What's D? Anhedonia, right? Things that maybe he used to find pleasurable, no longer, he does not find joy in those anymore. What are some of our major risk factors for depressive disorders? Without looking at the list, what do you guys come up with? Age? Okay, so young age or older age?
I think like teenagers and then like maybe after like you're 45, 50, when kids leave
Be
the
careful,
house.
45 is still pretty young. I'm just
Oh.
kidding. I'm like, oh my gosh, I'm 45 now. No, I'm just kidding.
I feel like it's a lot more common in high school.
Okay, high school age, college age, but then yes, you are correct. Like you kind of have that growing up phase, and then
Like after retirement.
and then people get they're so busy almost sometimes that
They don't.
they don't even notice what's going on, and then kind of that older population again. Okay, female gender is a higher risk factor. Adverse childhood experiences. What do you think about that? What do you think that means?
How you grew up, how you were raised, like what happened in your childhood could definitely affect.
Did you have a positive childhood, or did you have things that could come back and haunt you a little bit? Okay. What else?
Like the death of a family member.
Death of a family member. Yeah. And depending on what age you are, it could change your entire. I mean, any death can change the course of your life too. But maybe you are in the middle of growing up and you lose your mom or something, and now you don't have that familiar person in your life. Absolutely. How often do you think depressive disorders and substance abuse, whether it's drugs or alcohol, go hand in hand? Why?
Because
Most people use that as like a distraction from
Okay.
their depression.
Sometimes they use it as like, I don't want to think about this, so if I can't think about anything, I'm gonna have to feel better, right? Rachel, what'd you say?
Alcohol's like depressing, so it doesn't really help.
Yeah, it doesn't really help for sure, but yes.
Well, it's easy to get a hold of.
What's that?
It's easy to get a hold of, and the essential nervous stimulants helps depress the essential nervous system.
Yeah, absolutely. Chronic or disabling medical conditions, why do you think that's a risk factor?
If you have like something like MS where you can't move anymore.
Yeah. You have a disease process that changes your activities of daily living, right? Or chronic pain. It's exhausting to be in pain all the time. If you can't get up and move to do the things that you used to enjoy. So you maybe have that loss of pleasure because you can't do it anymore, right? Because of some chronic or disabling condition. Those two kind of go hand in hand. Absolutely. There are some different scales that a lot of times now I even noticed that when I went and saw the doctor a couple weeks ago, I had to do one of these online as like my pre-checklist. I had to answer very similar questions. Have you felt sad more than not, or do you feel sad more than twice a week? Or I don't remember the exact wording of the questions, but have you felt happy? Are you still able to do the things you enjoy? So oftentimes you have to do these kinds of things when you go to the doctor at least once a year. We give them to all of our postpartum moms before they go home so that we can kind of pinpoint, we need to make sure we probably call this patient sooner than the 2 weeks when we normally call them because they rated pretty high on the Edinburgh postnatal depression scale. So it depends on how you answer it, kind of the way you're going to look at resources for these patients. Now, how often do you think patients are 100% honest? Probably 0%, right? I mean, honestly, if we're gonna be honest, probably nobody answers them all 100% honestly. So if they are answering them and they get a higher level, they're probably looking for help. Because a lot of times they'll answer like, I know they're gonna ask me a lot of extra questions if I say that I'm sad. So we want them to be honest. Oftentimes they're not, so it's still part of our job to observe, to ask our questions, even if they come back and they're like, nope, I'm happy all the time, right? We just have to make sure that we are, observation in these kinds of situations is the best thing for us to do. A lot of things happen by just watching people, not even them talking or saying anything back. A lot of observation occurs and can give us a really good picture of how a patient is doing. If we talk about assessment in the nursing process, assessment of is a patient suicidal, that anhedonia. Stacy, how long has Avera had that ask the question? It's been a couple years already.
Probably, yeah.
So a lot of times people think, if I see a friend of mine who I think is very, very sad and I worry that she maybe or he maybe is suicidal, I don't want to ask him if he is, because then that's going to give him or her the idea to maybe go do that. So Avera came up with this thing that said, ask the question. So what do you think that means? What do you think ask the question means? Asking if they have thoughts of suicide. Okay? It's not probably giving them the idea, right? If we're asking them, it's possible that they've already thought of it. And sometimes people really just want to be heard, and they want somebody to say, oh, these people care. They're asking if I'm okay. So it's hard. It's really hard to ask somebody, do you have thoughts of harming yourself? But really, that is what we have to do. We have to ask the question, especially if we're really thinking that these patients could be suicidal. So if they answer yes, what's the very next question that we're gonna ask? It's also a hard question, but what's the next question? If I say, do you have thoughts of harming yourself? And they're like, yep, I do. And then what do you ask?
Have you tried to get help or you have they started feeling
Okay, even before these are great answers, but even before this, do you have a plan? And do you have means to that plan? Okay? People, I don't want to say often have thoughts of suicide, but if they have a thought, they don't often think, well, this is how I'm gonna do it. They just like, I wish I could die, right? It's not a great thought to have, but they don't often think of that next step. And if they've gone to the next step of like, okay, I really do want to, and now I have a plan in place, but do I have access to make that plan happen? So those are all questions that are hard to ask. They really are, but they're very, very necessary. Okay, and those are just some of the things that we look at if we're worried about the suicide. But asking the question is where we start. If they have a history of suicide attempts, that obviously kind of raises our bar a little bit. If they've tried to do it before, then we need to make sure that we have a plan. Also asking, do you have a recent loss, any recent traumatic events that are causing you to feel this way now as opposed to maybe last week? Okay. We've kind of talked about this a little bit. Patients with depression often don't want to hear our ideas. Have you noticed that? When we're in clinical, I know you guys are going to do a little bit more of that therapeutic communication this semester and learn how to do that, but are patients interested in our ideas? Very often, no. But we have to work really, really hard to try and get them to hear us, to maybe help make a plan for things. But if they don't want to, I mean, we can't force anybody to do anything, but making eye contact with them, helping them understand that we're here to care for you, right? And not feeling as a nurse that we've failed these patients if they won't talk to us. Just keep trying, keep working at it. Those are the things that we can do as nurses to try and help patients get through some of their dark days. Okay, which question would be a priority when assessing for symptoms of major depression? Tell me about any special powers you believe you have. You look really sad. Have you thought of harming yourself? Your family says you never stop. How much sleep do you get? Or do you ever find that you don't remember where you've been or what you've done? Which one do you think is priority? So if we're thinking, what's our number one thing that we need to ask this patient?
B,
Why?
because it's
Safety first, right? Yeah, B. Safety first. I mean, yeah, it would be fun to talk about the special superpowers that they think they might have. That might be another disorder that they might have going on. But, and asking about sleep is of course important, but safety, 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 right? Ask the question, have you thought about harming yourself? This is gonna be where we need to go. These are some of the nursing diagnoses that you could use if you are concerned about depressive disorders, chronic low self-esteem, imbalanced nutrition, I mean, there are a lot of things. Risk for suicide is probably our number one because again, that's that safety that we have to worry about for the patient. Disabled family coping, they don't have a good support system. It's going to be hard for these patients sometimes. Trying to find what motivates these patients to try and get help. If you can find something that they do find pleasure in, see if we can find some plan or therapy that includes some of those things that they can find positive. Okay, there's 3 phases. There's the acute phase. What do you think is our most important part of the acute phase in a patient that's going through a depressive disorder or that's going through an episode? That's the word I was looking for.
Keeping them safe, making sure there's somebody in the front.
Keeping them safe, okay? And just trying to restore their function, right? Restore their function to just how they were prior to, okay? So that's that first little bit. We're just gonna restore their function to hopefully prior to. Now, if we're in the continuation phase, what do you think is gonna be included in that? So this is like 4 to 9 months. What's that, Rachel?
like their care when they go home.
Yeah, their care when they go home. If something is working, or find something that works, right, and continue with that. If it works, what are we trying to do? We're trying to not have them go back to an acute episode, right? We're trying to just keep them in that continuation phase of with something that works. And then what do you think the maintenance phase means?
Just maintaining like that continuation phase.
Yeah, just trying to make sure that, and if you are on meds, are we able to wean you off of them at some point? If not, can we find a stable dose that helps you? Communication, 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 a couple more communications, right? We want these people to talk. If we can, we want them to have conversations with us, with their family, with their providers. We want our patients to communicate, okay? We want to help them learn how to live healthy. Like, do they need an exercise routine? Do they need a nutritionist? What are some things to help them try and stay healthy? Teamwork and safety again. We all know that teamwork makes the dream work, right? And keeping them safe, keeping the patients safe, keeping ourselves safe. Do you think depressive disorders or depression, like, it's gonna work the same way for every single person? Why?
So everybody's different.
Okay, everybody's different, right? I'm type 1 diabetic. I take my insulin. That's pretty constant, right? Any type 1 diabetic is gonna need their insulin. Now there might be other things that are needed for that diagnosis, but that's a constant. That's kind of cookie cutter, right? I need insulin to survive. Now, with depressive disorders, it might be the same diagnosis, and this patient needs counseling. This patient needs counseling and meds. This patient may need counseling, meds, and hospitalization. Like, it's all gonna be different. You have to evaluate each patient differently and not just have, Well, it worked for my last patient, so I know it's gonna work for you, right? We have to come up with plans that are unique to each patient. All right, who has the SSRIs? Who did the poster for SSRIs? If you guys wanna grab your poster, very quickly, how do we choose an antidepressant? You guys can grab your poster. Is it back there still? Should be. So SSRIs, after they talk, I'll see if kind of cover everything. But how we pick medications for choosing an antidepressant is we have to look at the patient itself, him or herself. We have to look at the profile. What is gonna be our best option for each patient? If you wanna come up here, oh yeah, you get to be in the, say hi to Dr. McCown.
Hey. Hey, boo. Am I
Are
by
you by
myself?
yourself? I was
I'm
gonna
not
say.
by myself. Hey, boo. Okay.
So you get about a minute to talk about it.
Oh. I'm not going back here. I'm up here. Okay, so we had SSRIs. Do you want to do the meds? Since you, if you could try to say that,
Prozac, Zoloft, Celexa, and Lexapro,
or the meds.
so they can treat OCD, eating disorders, depression, and anxiety.
Side effects: nausea and vomiting, sexual dysfunction, tremors and shaking, insomnia, and changes in your blood pressure.
Fewer side effects than other antidepressants takes about 2 to 4 weeks to have full effect, and Neuromed from the 1970s.
Okay, so what I want to know, or what I want you guys to kind of think about with these, is this is typically kind of your first line. One, because they have fewer side effects than a lot of the other ones. This is kind of your first line of medications. With that being said, what do you think, and you can't just abruptly stop them. You have to, if you start them, you have to kind of wean back down off them. I know I said that earlier. But of patients who are suicidal and they get put on a medication, what do you think you have to watch for? I mean, still suicidal thoughts, what did you say? Why? Why is it, she says increased risk of suicide, why?
Because they feel better, so that's
It sounds kind of dark, but yes, absolutely. Sometimes you're so sad that you can't even bring yourself to commit suicide, and then you feel a little bit better with some antidepressants, and everybody's like, oh, they're feeling better, this is great.
they can still feel depressed.
But they're still possibly depressed, and then they do have a higher risk of suicide sometimes after starting medication. So it's really, really important. Friends, coworkers, whomever, yourself, if you start antidepressants, that you have to really observe. Okay, good job.
Thanks.
Now,
Thanks,
the
Doc.
SNRIs. If everybody, and then MAOI inhibitors, who has that one? Is there only 3 of you?
We're LAY.
We're MAOA.
Okay, if you wanna grab it quick, and then once they're done, just so you have it.
Alright, so we had SNRIs. The main meds we had for this were duloxetine, venlafaxine, and desvenlafaxine.
Basically we said like no smoking or nicotine products, and then also like increased fibers, and it's best if it's used daily, and it normally takes 6 to 8 weeks to work.
And it's used for PTSD and kind of some generalized depression disorders.
Some side effects are drowsiness, anticholinergic effects, dizziness.
Why do you have a baby on there?
That's just because they're sleeping.
Sleeping, okay.
Another use was the
Diabetic.
perks, yeah. Like,
Diabetic what?
I really,
Neuropathy.
Oh,
neuropathy,
okay.
neuropathy.
I don't know if I knew that. All right.
Yeah.
MAOI?
Okay, so for MAOIs, there is non-selective and selective. So like the non-selective ones are the ones that have been used for mood for a long time, and then the selective ones are like the newer ones that they're using for Parkinson's.
Right, so we had, I mean, this is just kind of an illustration, but we had what it's like before you start taking your MAOIs and then what it's like after. And then side effects, we had restlessness, insomnia, anxiety,
This one was like
Dizziness.
dizziness.
Yeah. fatigue, malaise.
And then down here, for MAOIs, you want to avoid foods high in tyramine. So like no aged meats. We have like a pepperoni pizza, and then cheese, goldfish.
Fish.
No fish.
No
Well, I know
fish.
there's. And then no alcohol or milk. What's that? Chicken.
No, that's fish.
Oh, that's fish. Okay.
And then for disorders, we had like anxiety, like a panic disorder, and then what's else? Like a manic.
Oh yeah, man, yeah.
Manic disorder.
And then it can take a few weeks to take full effect.
So what happens if they do eat food that's high in tyramine?
It can cause the poisoning. What's I don't know what's called.
What happens if
It's like I don't remember what it's called. Yeah, I don't know what it's called. They have a reaction. Crisis. That's what I was
Yeah,
looking
very
for.
quick medical attention. They can have stroke, have seizures. It can be very serious.
That's what it is.
All right, really quickly, we are going to, I'm gonna throw up a video of ECT therapy, electroconvulsive therapy. I am hoping that when we go to Yankton, you guys will be able to see that. I'll you pass them out here. So I'm gonna show a video. Do you guys have any questions about anything I went over? Because I'm gonna stop the video of me right now. Do you guys have any questions before we watch the video and kind of finish up class? What did you guys learn today that you didn't know before you came in today?
Like the reason why suicide is higher after they start taking antidepressants.
Okay, never thought about that before. I know it's kind of a different thought to have, isn't it? Okay?
All the effects that go into like postpartum depression, if you had depression before, you're more likely.
The risk factors of postpartum depression. Absolutely. What can happen if you eat foods high in tyramine and you're on MAOIs? Absolutely. Okay. Any other questions for me? Well, I'm gonna start this video, and you guys can work on this worksheet while we're watching the video, and then we'll be done. All right. I'm just kidding.